This is Allie Orwig with the Indiana Rural Health Association. I want to thank everyone for joining us today. We are going to go over a couple quick housekeeping items and then get started with our presentation. This meeting is in the meeting format today, so we do ask that if you are not actively presenting or asking a question, you keep your line muted. Helps cut down on some of the background noise and interruptions. If you do need to send a message during the presentation, you can use the chat function, which is found the exact same way you find the mute button. Actually, you hover either at the bottom of the screen or the top of the screen, depending on which view mode you're in, and you should be able to find the chat window. I'm just sending one to everybody really quick so you can see how that looks. If you do have a question, I will try to keep an eye on that during the presentation and act as a moderator, but we'll certainly get to any and all questions by the end. As usual, we are recording today's session, so if you join late or if you have to jump off, we will have this on our Indiana Rural Health Association YouTube channel later, and we'll also be sharing the link with members of our Indiana Rural Opioid Consortium Planning Grant Consortium members, which is quite a mouthful. But without further ado, I think we'll go ahead and turn it over to the ladies at IU.
Hi everyone, I'm Dr. Joan Duwve, and I'm the Associate Dean for Practice at the Richard M. Fairbanks School of Public Health at IUPUI. I'm also the Director of the ECHO Center, and I'm joined by my colleague Andrea, and I'll let her introduce herself.
Hi, I'm Andrea, Janota, and I'm the ECHO Program Coordinator for the Fairbanks School of Public Health Center for Public Health Practice.
Yeah. And we are really honored to be partnering with the Rural Health Association and with our colleagues at IU Bloomington and the Center for Rural Health on the opioid planning grant, as Allie mentioned. And as part of that grant deliverable, we would like to talk with you about Project ECHO, which is a project that we brought to Indiana last year. And so we thought it would be a great idea to share this with you. I'm going to share my slides.
Blue share in the corner right there.
And I'll get rid of this. Great. Here we go. So I'm using a different screen. We have one that's on the wall, and then I'm using my laptop because my eyes are old and it's easier for me to see. And occasionally I get messages that are flashing in front of my screen, so sorry if I stop and look startled. So today we're going to welcome you to Project ECHO. We learned about Project ECHO during the HIV outbreak in rural Scott County, Indiana. And you're probably all very familiar with the outbreak of HIV and hepatitis C related to injection drug use in Austin, Indiana, just a small community of 4,200 people in southeastern Indiana, in the rural county of Scott County, which is about 24,000 people. When we learned about the HIV and the hepatitis C outbreak, we quickly began looking for providers to treat folks who had become infected, knowing that we had the opportunity with treatment to reduce viral loads to the point where people would no longer be infectious to others, even while injecting drugs. So that was one of our first priorities in order to interrupt transmission of HIV. We were quite shocked, actually, when we learned that there were no providers in Scott County who could treat people with HIV or with hepatitis C. The closest provider was, well, there were two. There was one in another Indiana county about an hour away, an infectious disease doc, who told us that he would not see patients from Scott County who were covered with Indiana Medicaid. Then there were also providers in Louisville, Kentucky, about an hour away. And those providers would see patients, but they had long waiting lists. And in addition, many of the people who needed treatment didn't have transportation. We couldn't get them to Kentucky. So we knew that we needed to do something to develop capacity right there in Scott County. Just a little reminder about the outbreak. Actually, as of the end of 2018, there have been 236 individuals diagnosed with HIV and nearly 95% co-infected with hepatitis C. And this is just sort of a picture to show you where Austin is and Scottsburg, and just in the middle of the rural southeastern portion of our state. So I'm going to go back a slide. We did know that in Austin, Indiana, we had a primary care provider, Dr. Will Cook, who was interested in caring for the population. In fact, he had moved to Austin, Indiana about 10 years before the outbreak, specifically to provide care to this underserved area of the state. Unfortunately, Will had not been trained to treat patients with Hep C or with HIV. We quickly learned about Project ECHO. And what Project ECHO did was allow him the opportunity to get trained by a provider in Connecticut who was already treating patients at an FQHC, treating patients for hepatitis C and HIV using the ECHO model. Will quickly joined Project ECHO and began treating patients. And this slide just demonstrates the increase in acute and chronic hepatitis C in Indiana to show you that Scott County is not the only county that was seeing an increase in rates of hepatitis C. And what you'll see is all of the counties in red had seen between a 200 and almost 700% increase in the number of people being diagnosed with hepatitis C between the years 2011 and 2016. So we were focused on Scott County because of the HIV outbreak, but across the state of Indiana, we had counties that were seeing these tremendous rates of increase in disease. And most of these related to injection drug use. And these are rates that just show where in the state of Indiana we have high prevalence of HIV/AIDS, and the slide on the right is to demonstrate that in Q1 of 2018, which is the most recent data we have, the people who were diagnosed with hepatitis C just in that quarter, the darker blue, the more people. And these are rates per 100,000, but you can see that this corner of the state of Indiana continues to see high rates of hepatitis C, as do other areas. And again, these are areas we know also have high rates of opioid use and injection drug use and overdose, emergency department visits, and death. This slide just demonstrates the tremendous cost, the burden of hepatitis C in the United States in terms of dollar costs, but also cost to the already overburdened rural healthcare delivery system, and cost to patients in terms of liver failure, liver cancer, and death. And here I just demonstrate that, that many rural communities in Indiana do not have sufficient specialist physicians. And this is just specialist physicians in general. This doesn't really say anything about the infectious disease treatment capacity or that the hepatology treatment capacity in these rural communities. So we have underserved communities, and the lighter slides are the the darker slides actually are the communities that have actually the fewest infectious disease or the fewest specialty physicians per population. The other slide, the slide on the right, demonstrates primary care physicians' populations per FTE ratio. And so what we see is that, again, the rural communities are in the darker colors, have fewer full-time equivalent primary care providers in the state of Indiana. So we do have a shortage of not only specialty physicians, but also primary care providers to help treat patients in the state of Indiana. We know that to treat hepatitis C, what we need is we need primary care providers who are diagnosing and have the ability to treat patients, and we need to get them trained, and we need to help expand coverage for the treatment of hepatitis C. And we can talk a little bit more about that later. And we know that the barriers include lack of referral, specialist capacity. So if I were in an underserved community and I wanted to refer a patient, it might take 6 months to 9 months to get that patient in to see a specialist, to get their disease treated. During that time, because we don't have adequate treatment, the patient may have already been diagnosed at late stage illness. And during the time the patient waits, that disease could progress. And we'll hear the story that really started this ECHO program in New Mexico, and how that really played an important part in the creation of this program. And what we see here on the left is this cascade of care for those infected with hepatitis C, and this is nationally. But as I mentioned before, if we can cure, and we can now cure hepatitis C, we can prevent ongoing transmission, we can prevent the loss of life, we can prevent the tremendous expense, and we can actually reduce the burden on our rural and statewide healthcare capacity. Unfortunately, only a small percentage of individuals with hepatitis C have been treated, 9%, and fewer than that have actually achieved cure. This is a little bit old, so I'm hopeful that those numbers have increased, yet we are nowhere near where we need to be in the diagnosis and treatment of hepatitis C. So this is just a slide to talk about what we need to eliminate these diseases in our state. And this was all based on Scott County. We needed increased testing, we needed increased vaccination, increased access to treatment in our communities by our primary care providers and in our correctional facilities, and then the harm reduction programs and decreased stigma. So Project ECHO, we learned about Project ECHO, and we hooked the primary care provider in Scott County up with Project ECHO. And the next slides will show you exactly what about ECHO really excited us, what is ECHO, and hopefully by the end of this discussion, you too will be excited about this project. So back in 2003, when ECHO was sort of conceived at the University of New Mexico, there were 70 million people in the world infected with hepatitis C. And New Mexico had a very large burden. Unlike many states, the injection drug use epidemic in New Mexico never had a nadir. So most states saw increases in injection drug use in the 70s, decreases over the 80s and 90s, and then again started to peak in the 2000s. New Mexico, the curve is fairly flat, it's straight. There were high rates of injection drug use, those high rates continued, and they continue today. By 2017, in rural New Mexico or across the state, 5,300,000 patients.
53,000.
53,000 patients. Sorry, I have had a very long weekend. Have tested positive for hepatitis C antibody. In 2004, less than 5% of the patients had been treated. And many prisoners in the state correctional system were positive, and none of those were treated. The good news, even back in 2004, was that hepatitis C was curable 70% of the time. The regimen was complicated, but it did work. The bad news was that it was complicated and there were severe side effects. And no primary care physicians had been trained to treat patients for hepatitis C, and no primary care physicians were treating patients for hepatitis C. And often this was because primary care providers thought, oh, this is too complicated, there's a specialist who can do this. But there were also insurance policies, that third-party payer policies that said you, if you're a primary care provider, cannot treat patients for hepatitis C because you don't have the knowledge. So there were barriers, many barriers to getting patients treated. Rural New Mexico, New Mexico is a very rural state. It's a large state with about 2 million people spread across the entire state. About half are Hispanic, 10% Native American, and the poverty rate was very, very high compared to the national poverty rate, and many people lacked health insurance. 32 out of the 33 New Mexico counties are listed as medically underserved areas, and 14 were health professional shortage areas. So there were no providers outside of Albuquerque. The goal of Project ECHO was to develop the capacity to safely and effectively treat hepatitis C in all areas of New Mexico, and then to monitor the outcomes. So if we train primary care providers to treat patients with hepatitis C, how will those patients do? Will they do as well? Will they do worse? Or will they do better than patients that are treated at the academic centers by the specialists, the gastroenterologists, or the infectious disease docs? And a model was developed to treat those patients with this complex disease in rural locations. And as you'll see, this model was then spread to across the nation and to many developing countries. So what is Project ECHO? Project ECHO is a lifelong learning and guided practice model. It revolutionizes medical education, and it increases workforce capacity to provide best practice specialty care, reduce health disparities through a hub and spoke knowledge sharing network. So that's a lot of text, but essentially in a sentence, that is Project ECHO. And we're going to break this down throughout the next part of the presentation. We know that people need access to specialty care for complex conditions. We also know that there are not enough specialists to treat everyone, especially in rural and underserved communities. And we firsthand got a taste of this in Indiana, in Scott County. But also, as we're talking about the opioid epidemic, we know that there are not enough addiction psychiatrists to treat. There are, you could count them on probably 2 hands. Maybe now you'd have to take off your shoes. Still, that is not enough capacity to treat the patients across the state of Indiana with opioid use disorder. If we relied on the ability to train enough addiction psychiatrists to treat people, we would not be able to treat patients with opioid use disorder or hepatitis C or HIV across the state of Indiana for another decade or more. So obviously that is not the right answer. It's part of the answer, but it doesn't provide us with enough capacity to treat. So ECHO is a model that trains primary care clinicians to provide that specialty care so more people can get the care they need. And not only do they get the care they need, but they get it in their own communities. So we like to say that with ECHO, patients get the right care in the right place. They get it at the right time when they need it. They don't have to wait for 6 months or 9 months while their symptoms get worse, while perhaps they continue to infect other individuals transmitting hepatitis C or HIV. So what happens is that we get improved outcomes at reduced costs. And not only that, patients are happier and providers are happier, which are really key to the success of this project. So how does Project ECHO work? Project ECHO is really case-based discussions that train providers to treat patients. And so we say that there's a learning loop. We have a specialist team or a hub team that sits in a central location. Using this very platform, Zoom, that the knowledge from the specialist team is shared with primary care providers and their teams. The team-based learning is, I think, a really critical part of this whole concept. So the knowledge is shared with others in the community, and we actually share knowledge with our hub teams from the Fairbanks School of Public Health. The spoke teams, those are what we call the teams who are out in the community, come from around the state of Indiana. So the knowledge gets shared by the hub team to the spoke teams, but knowledge also gets shared between the participating spoke teams, so they learn from each other, and then the hub team learns from the spoke teams. So it's a learning loop where everyone is sharing knowledge with each other. And when we first started doing this, I have to say, I'm like, yeah, you know what, the hub teams, they're going to be sharing knowledge, but what are they going to learn from people in the community? What happens is that what we learn from people in the community is what's happening in the community, how they're managing patients. So we're learning this emerging best practice that primary care providers are doing in their own practices in the community in order to help their patients the best they can. And this could be practice around getting patients into the office for care, for following up on patients that don't come in. How do we get a hold of those patients and urge them to keep, their appointments? How do we actually work with third-party payers to make sure that our patients, the treatment they need is covered by those third-party patients? And then what about stigma? Many times the specialist teams who are at academic centers really, don't have the time or aren't in the rural communities and don't have the experience with patients. And so sometimes what we hear is stigmatizing language or perhaps barriers to treating patients that our docs in rural communities have long since gone beyond. So it was surprising to us to see the amount of knowledge that the specialists were learning from our primary care providers, in addition to primary care providers learning from the specialists. So how is this different from telemedicine? Well, with ECHO, we are not treating patients. We are training providers. The providers always maintain the control of the treatment of their patients. With their patients, they make those treatment decisions. The specialist team is a curbside consult, if you will. Training those providers, the providers are training each other, and then they are all going back and treating multiple patients. ECHO calls this force multiplication. Force multiplication is a term that's used in the military and describes exactly this, how having a team that trained one person would actually affect the outcomes of dozens of people. With telemedicine, you have one provider treating one patient, so you never develop increased capacity. ECHO develops increased capacity to care for patients in the communities where they live, in their medical home. And as you might imagine, there are a lot of benefits to that kind of model. Oh, here it is. So it's moving knowledge, not moving patients. The patients don't have to come to an academic center. And you are helping the patients by getting them care. You are helping providers acquire new knowledge. They can treat more patients. Often, This is helping them practice at the top of their license, so the patients they're treating may have, that the treatment may allow them to bill at a higher rate. So you're developing the capacity so they can actually have a successful practice, and you're building a community of practice. So the rural providers don't feel so isolated in their communities, because now they know rural practice providers in other communities who are doing the same things, and they meet with them regularly. The communities, the outcomes in the communities are reduced health disparities. So I think it's probably no surprise that folks who perhaps don't have a car or can't afford to travel from a rural community to Indianapolis, if you don't have a provider in the community, they won't get treated. So by building the skill of providers in communities, we are actually reducing health disparities across the state of Indiana. In addition, provider retention in the New Mexico model was increased. Providers were happier practicing because they didn't feel helpless. They didn't feel like they couldn't treat their patients, or they'd send their patients off and they never heard back from the specialist provider. They were able to do more to keep their patients healthy. And the patients actually did better because they were able to stay local. So they had their support systems, they had their home, they had their family, they didn't have to spend a night in a hotel. If they needed to access ancillary care in the community, it was really a network that was based locally. And so it was easy for them, less stressful, and patients actually just do well in that kind of model. And so then for the system, we're increasing access, improving the quality of care by training providers, by using the specialists with advanced knowledge to train those providers, and the cost of care is greatly reduced. So I am going to see if I can play this for you. It's just a quick little video. Do I need to share this as well? Mm-hmm. Okay.
Do you want to pause it real quick?
This?
Yep, so it doesn't keep going. And then go back to your Zoom and say stop share. Then start share again. And click on the one with the video. Share.
Thank you.
Thank you.
Technical assistance.
You can do it full screen.
Yeah.
Okay, go ahead and pause it one more time.
Okay, but we're not getting the volume.
Yeah, you'll have to probably play your volume, but let me turn it off here first.
Over here. Sorry for the technical difficulty. And it's done. Okay.
So mute yourself here.
Well, we tried. And so these slides will be available to you, so you can feel free to go to the link. Sorry about the technical difficulties here. So now I'm going to go back to the presentation. Oh, not there. There. Okay.
Blue share.
Nope.
We had your slides back for a minute. Yep, they're there.
Oh, okay. We don't see them on our end, but that's weird. But you can see them okay, Allie?
Yes.
Okay.
Okay. Oh, good. Thank you. Yeah, because we can't see them here. Oh, wait, now we go. Okay. All right. So I'm not going to go over that other little handout, but it essentially says the same thing. So this is what an echo looks like. You have your providers sitting around a table in the room. These are experts. So the experts are multidisciplinary. You may have an infectious disease doc, a hepatologist. You will have somebody who does behavioral health. So it could be a clinical psychologist or a psychiatrist. You have a social worker, somebody who does insurance billing. You may have an attorney who does legal aid. You may have an advanced practice nurse or a primary care provider who's actually treating patients with complex conditions, who might be able to translate some of the technical jargon to the providers or answer questions about that are more primary care related. If you're talking about hepatitis C, you may have somebody who's an expert in addiction, since we know that hepatitis C is actually primarily caused by injecting drugs. Depending on the topic area, you'll form the expert team around the needs of treating patients with that particular condition. And then you have folks who join from communities all across the state. And they will join using the Zoom platform and their video cameras. And you may have some teams here. You may have people joining alone. And the ECHO session actually proceeds. So it starts with a didactic presentation, just a brief didactic that will be introduced by somebody at the hub team, one of the experts. So they may talk about hepatitis C 101. What are the basics of hepatitis C treatment? What about hepatitis C testing? There may be a didactic around motivational interviewing. How do you work with patients to encourage them to make changes in behavior? There may be a didactic around stigma. How can we as providers work with our patients using language that respects their autonomy as human beings and not defining them by the disease process that they have? There may be a presentation on treating patients with hepatitis B virus who are co-infected with hepatitis C virus, or treating pregnant women with hepatitis C. Every session will be a different didactic. Those didactics are kept very brief, about 20 minutes. And honestly, the less said in a didactic, the more room there is for discussion. And that's what we like to see in ECHO. We like our participants thinking and asking questions. It keeps them engaged, and it's actually better for active learning. So if we spoon-fed them everything, they'd be multitasking, doing something else, not listening. But if we give them just enough, allow them time to ask questions, encourage discussion, then we have more robust learning. So that's what happens first. And that's followed by a case presentation. So one of the participants, say the PCA Española, will present a case. It's all de-identified information. As I said, we're not treating the patient. But a case will be presented, and it's presented usually 5 minutes or less. So again, providing just enough information for us in order to really encourage a lot of conversation. So, you know, a 26-year-old white female with history of injection drug use was diagnosed with hepatitis C 3 years ago. The patient wasn't interested in getting treated, but now is starting to, you know, feel depressed and sick, and also diagnosed with diabetes. And so how might I encourage this patient to get treated? And so just a short, and then maybe there'll be some lab values if there's been any imaging done, so that we understand what stage the disease process is. No identifiable information. We don't know where the patient works. We don't know where the patient lives. We have a general idea because we know where the provider is practicing, but nothing that could help us identify the patient. And we really are very, very careful about that. So then the participants will have a chance, other participants will have a chance to ask questions. So somebody from Pecos Valley might say, thank you for that presentation. Do you know if your patient's been vaccinated for hepatitis B and hepatitis A? We're having an outbreak of hepatitis A. PCA Española will say, That's a good question. The patient has been vaccinated for Hep B, but not for Hep A. Then somebody else will ask a question, and it will go back and forth like that, clarifying questions. So the providers have a chance to interact with each other before the experts ever get a chance to open their mouth, because we all know what happens when experts open their mouths, right? And our experts are wonderful, but they have so much knowledge, and they're all educators, and they want to share. The purpose of this is obviously to allow the experts to share, but we're really trying to develop that same level of expertise in our providers. So we want to do whatever we can to encourage them to participate. So once our providers have finished asking their clarifying questions, our team, our hub team, will have a chance to add additional clarifying questions. And many of those clarifying questions are more targeted. But again, our providers in the rural communities and our underserved communities learn from the questions that are asked by the providers, and they start to think about those questions as well. Once we're done asking questions, we'll talk about recommendations. We go back to our spoke sites and we'll say, what recommendations do you have for PCA Española to help them treat their patient at the best they can? And we'll learn from others what they're doing to treat their patients. Perhaps somebody has more expertise on treating patients with opioid use disorder, and they might provide some great information back to PCA Española about helping this person with injection drug use, which is a really important thing when you have somebody with hepatitis C, or just in general. Somebody else may talk to them about making sure how to help the patient be compliant with those visits. What can the practice do to help the patient with compliance? Because we know that compliance with hepatitis C treatment is really critical. Somebody else might talk about how it's really important to get patients with diabetes, that have diabetes as a co-occurring illness, treated for hepatitis C, and how that might actually help get authorization from an insurance company, from a third-party payer, to pay for the Hep C treatment, because it's a complicating factor with hepatitis C disease. So that is how the learning occurs in these sessions. So again, the hub team supports the primary care teams through these clinics, and then all these patients get reached with treatment. So it's not telemedicine, but it's actually force multiplication. So how well has this model worked? We're gonna just go. So there was an evaluation done after the first hepatitis C echoes in New Mexico, and the ability to identify suitable candidates for treatment before people participated was 2.8, and after participation was 5.6. So the ability was doubled. And the ability to assess the severity of liver disease also improved. The ability to treat hepatitis C patients and manage their side effects more than doubled, actually. So, so we know that the providers are learning. And we see this across the board to assess and manage the psychiatric comorbidities in patients with hepatitis C. So it's not only did these providers learn about hepatitis C treatment, diagnosis and treatment, but they also learned through this echo about managing psychiatric comorbidity. Many of them actually became known as the hepatitis C experts in their communities and served as a local consultant, which was really great for those providers. And they were able to educate and motivate. So that motivational interviewing, working with patients, their confidence and their ability to do that greatly increased. And overall, the competence, what we saw about a doubling in terms of the competence of these providers. And so what they perceived as benefits from this Hep C echo, this inaugural Hep C echo, were they saw that there was an enhanced knowledge about management and treatment of hepatitis C. 97%, 94% thought they were well informed about symptoms, and 98% felt that they had achieved competence in caring for hepatitis C patients. And those are huge. So, you know, more than 9, almost 100% of providers actually developed a skill that they didn't have before. And so a survey that was done at an annual meeting of these providers also addressed provider sort of well-being in their communities. And out of 5, 4.3 said that Project ECHO had diminished professional isolation, about 4.8 out of 5 said that it had enhanced professional satisfaction, that 4.9, almost 5, said that it was a benefit to their clinic, that it expanded access to treatment in their community, and that these needs were major areas of need for their clinic and for their communities. So ECHO actually filled this need very, very well. Outcomes, let's see, a study was done at community-based clinics and Department of Corrections, and the principal endpoint was sustained viral response after completion of treatment. And what was done was those rural ECHO providers were compared to providers treating patients at the University of New Mexico in Albuquerque. And what the outcomes showed was that for minority patients, ECHO providers were successfully treated 68% of their patients, whereas only 49% had been successfully treated at the university. And then those achieving cure were actually equal to, or in the case of genotype 1, slightly better than the outcomes that were seen at the university. Now, this is when, again, hepatitis E was much more difficult to treat. So the beautiful thing now is that we have a really easy treatment regimen that we can use for hepatitis C. It's still complicated to get patients diagnosed and worked up and to follow them during treatment, but the side effects of the medication are rare. Sometimes there are drug-drug interactions, but mostly patients tolerate these medications very well, and the cure rates are much higher. So, you know, if using this complicated regimen, the ECHO providers can have better success rates treating patients, even though it was not significant, equal or better, with these standardized regimens that are easier to use. These outcomes will be fabulous. So the conclusions were that rural primary care clinicians were able to deliver hepatitis C care using Project ECHO that was as safe and effective as that given in a university clinic. And that Project ECHO improves access to hepatitis C care for New Mexico minorities. And these studies just report on additional trials that were done, and I'm not going to go through them all. This one, however, I think is of interest, and we'll have another session that specifically talks about ECHO for opioid use disorder. But this was the availability of medication-assisted treatment in New Mexico in traditionally underserved areas. And as we know in Indiana, it's very difficult. Access to medication-assisted treatment in rural communities is difficult and sometimes not existent. And so patients need to travel long distances to get to an opioid treatment program if they want treatment for their opioid use disorder. Same thing was true in New Mexico. When opioid use disorder ECHO was introduced in New Mexico, actually it was an addictions tele-ECHO clinic, we see the number of MAT waivers, buprenorphine waivered physicians per population exploded. And this is what happened in other states. So the introduction of ECHO, which allowed primary care providers to learn how to treat patients for opioid use disorder and addiction, and learned from a panel of specialists. They could present their cases. They became more familiar with the treatment, more comfortable with the treatment, and began treating patients. And as these clinics continued to occur, the ECHO clinics continued to occur, more and more providers became excited about treating patients in their communities, joined the clinics, and learned how to do this and began offering treatment. I think this is a really nice depiction of not only what happens with opioid use disorder, but what we're seeing happen with hepatitis C. We're seeing providers who want to treat patients for HIV, and what the potential for ECHO is in the state of Indiana. And I'm just going to show this picture. ECHO also works in the prison system in New Mexico, and you'll hear a little bit about this later, to train community health workers inside correctional facilities to work with the other folks who are incarcerated to help them lead healthier lives inside the correctional facility. And hopefully that skill will get translated when folks are released from incarceration. All right. Project ECHO now, it is in 34 countries. There are 270 hubs across those 34 countries, and 598 ECHO programs exist, are offered by those hubs. In the United States alone, 46 states, and I'm happy to say that now Indiana is an ECHO provider, 166 hubs, and 404 ECHO programs have been introduced. And you can see along the side just a little bit, just A through C, of what is offered using ECHO model. In Indiana, we started ECHO, as I mentioned, in January of 2018, and we started with hepatitis C. Now, I'm happy to say that we offer hepatitis C, LGBTQ, HIV ECHOs, and opioid use disorder ECHO is offered by the School of Medicine Department of Psychiatry. We will be introducing pain management ECHO in the spring, and a corrections peer education project ECHO with our Department of Corrections, and that is going to be launched in the spring as well. And we're currently working with the Cancer Consortium to model a cancer ECHO here in Indiana. If you're interested in learning more about each of these ECHOs, you can go to this website, which is echo.iu.edu, and you'll see listed across the bottom the ECHOs that are currently offered. You can just click the bullets and it'll take you right to the site. So this is what our Hep C ECHO looks like here. This is the hub team. We actually now have a new ECHO room. We're not in this room anymore. We have a bigger room with 2 screens. It's beautiful. But you'll see the hub team, the depictions of the hub team. I forgot to mention there's always a pharmacist on the ECHO. And this is just one of the didactics that we had in our hepatitis C ECHO. And this was done, presented by Dr. Erica Kaufman-West, who's an infectious diseases doctor. And she actually practices up in the Lake County area. And she was part of the Missouri ECHO project before she moved to Indiana. So she's a real champion in our state for ECHO. And I just wanted to show you, we're very results oriented. Using the ECHO model and getting trained to treat patients with hepatitis C and HIV, the primary care provider, Dr. Cook in Austin, Indiana, has been able to get individuals in that community who, many of whom are still injecting drugs, those individuals with HIV, 76% of them are now virally suppressed. That number actually may be 77% at this point, which is tremendous when you consider that many of these individuals are in and out of jail and lead chaotic lies. So 77% viral suppression, that's a higher viral suppression rate than many infectious disease docs have for patients in their treatment portfolios. So we're really pleased, and you know, this is really a testament to the power of ECHO in the state of Indiana. There are new HIV and viral hepatitis treatment targets. Not only the World Health Organization, but now the president even talked about eliminating the ongoing transmission of HIV in the United States. So we have a lot of work to do in the state of Indiana. The Grand Challenge here at Indiana University recognized the power of ECHO and actually provided some funding for startup. And we're happy to say that we were the recipients of that funding and are continuing to leverage those funds and bring in an additional funding through grants and partnerships. This is an older map, but you can see the reach of ECHO. And each color represents a different ECHO track, but we're blanketing the state with ECHO providers. So we have a plan. We're working on sustainability. We'd love to introduce more ECHOs. We hear people ask for community health worker ECHOs, for endocrinology ECHOs, particularly around the treatment of diabetes, prevention and treatment of diabetes. An accreditation ECHO working with local health departments. Really with ECHO, the sky is the limit. These are our partners. I'm sure there are people that I've left off this list. It has been a tremendous opportunity for us to work with others, both in state government, governmental public health, and folks like the Rural Health Association, the Primary Health Care Association, our medical academies. We're actually presenting at the osteopathic spring meeting and the Indiana Academy of Family Physicians meeting. Eskenazi Health has been a tremendous partner, MedIQ, many more. And we're on social media, so follow us at Indiana HCV Echo. There's our Facebook page. And thank you. Happy to answer questions.
Yeah, thank you, ladies. I haven't had any chat questions come in yet, but we can go ahead. If anyone would like to unmute their line, you can ask a question verbally, or I will keep an eye on the chat window as well if you'd rather type a question in.
Doctor, this is Jim Miller with the Indiana Rural Health Association. First of all, thank you for your presentation. It's very enlightening. I learned a lot about the ECHO program today. I'm a reimbursement finance guy, so any kind of programs that you know, I'm interested in is how you're going to pay for it.
Right.
And I see Medicaid was listed on there. I was curious if the state has had to do any type of specific waiver efforts, or any type of special efforts through CMS to help fund the ECHO program. Could you kind of illuminate a little bit about how the state is involved in that regard?
Yeah, that's a really great question, and we're not quite there at the answer for sustainability yet. What we have done is, you're probably aware that there's a lot of federal money now that's being given to states to respond to the opioid epidemic. In addition to respond to the infectious diseases that we're seeing dramatic increases in as a result of injection drug use. So we've worked with our state partners to capitalize on those opportunities. And the State Department of Health has really been a phenomenal partner in working with us to get ECHO projects up and running. One of the ECHO projects that we are working with them, that we hope to be working with them on, we're currently just in the process of writing a grant proposal, is a community-based opioid response ECHO. So what this echo will do will be working with teams from communities, and those teams will join, as you saw, the physician teams. So it's not a medical echo, but it's a community response echo. So you might have elected officials, county commissioners, you might have physicians, you might have first responders, you might have a prosecutor, you'd have the local health department. They would all be part of a community response team. And then you would have teams similar to that across 12 to 15 different communities. And we would bring in experts probably at the federal level, but maybe from other states as well, to talk about opportunities that communities might think about adopting in order to respond. We would have communities present a project that they did that seemed to be working in their community and share that with other communities. So it's an opportunity that we're really excited about, and the State Department of Health is very interested in helping us to get that up and running. With Medicaid, Medicaid has funded the opioid use disorder echoes through, actually it's not Medicaid, it's FSSA, the Department of Mental Health and Addiction, through the 21st Century Cures Act funding that SAMHSA offered. But what Medicaid has done with us is they have actually included providers who are echo trained on their prior authorization form for hepatitis C treatment. As you know, it's pretty expensive to treat patients with hepatitis C. And what they've seen at Medicaid is that primary care providers who request prior auths who are not echo trained don't seem to be providing the right information. They're not approaching the patients in the most evidence-based way. But providers that are participating in echo look very similar to the specialists. So they have allowed our providers to treat patients for hepatitis C without denials, and they will often deny other primary care providers. So it's a real benefit to our providers. So for ongoing sustainability, we have just hired a communications expert, and actually Joey's sitting in the room with us. And Joey is working to get the word out about echo. We really want to increase brand recognition across the state. And there have been conversations, but they've been short-lived conversations about perhaps a model where the state might provide some funding in the state budget. We know that this happens in several other states. We know that our federal agencies are very supportive of this. Everyone from CMS to SAMHSA to CDC. The question is, how do we make it work? And then there are two missing pieces to this puzzle, I think. One of those missing pieces is other third-party payers, commercial third-party payers. They obviously stand to reap many of the benefits in terms of cost savings for if we do this work and we do it well. So how does that get sort of translated back into support for this project? Not only support for the Echo Hub team and the services we provide, but also support for the providers who are taking time out of their day when they could be seeing patients to learn how to provide quality care. So could there be sort of tiered reimbursement? So if you're an echo provider, we know that you're interested in practicing at the top of your license in providing quality care. Perhaps you should be reimbursed at a higher level. Or could there be reimbursement for the time that providers spend during the day? That's, I think, another option. And then the final missing piece is our healthcare provider systems. So as I mentioned, Eskenazi has been an amazing partner, allowing their providers to help as part of our hub team. But other healthcare providers, it's been a little bit more difficult. Those healthcare provider organizations also stand to benefit a lot from having their providers participate. But I would suggest that it would be helpful to everyone if they had some skin in the game as well. So thanks for that question. It's a really important question, and it's one that keeps me up at night, actually.
Thank you, Doctor. I appreciate it.
Mm-hmm.
Okay, any other questions? Well, hearing none, I'll just thank you ladies again for a really excellent presentation. Again, if you think this might be something that someone in your organization should see, or possibly you have providers that might be interested in learning more, we have recorded this session. We will have it available. I'm going to actually give you all my email address for those of you that don't have it in the chat function. And if you want to send me or either of the ladies from IU an email, I know they shared their information there at the end, we can get you the recording link and or the slides from today's presentation. So thank you all so much for joining us. Hopefully we'll see you back for our opioid use disorder echo in a few weeks. So thank you all very much.
Thanks, everyone.
Thank you, Allie. Thank you for joining.